take some questions, and also to mention for the people who are listening, watching virtually, that they should put their questions into the chat as well. I guess we'll open up to the room first of all, just to see if there's any questions. Yeah, so I was just going to, is it okay just to ask a couple of questions about the cases we presented? So just to point out a couple of kind of points which I think everybody knows, but this idea where we can move across the pathway from transplant eligible to non-transplant eligible because of the dynamic frailty that we talked about, and it's just important that everybody is aware that you can do that, and that might be something to consider. So that's made things a lot easier for many sites.
Yes, I think so. And you're right. Not everyone may be aware, and I think practice might vary from centre to centre. But I think it's not unreasonable to start with considering not being sure whether the patient is fit enough for a transplant, because things change between first presentation and then after induction therapy. So it's not unreasonable. But I guess the principle is always to try and figure out what would be the best treatment for your patient, all things being equal and available, and then try and see how you can make that work within the constraints of nice approved therapies at the time. I think that's the principle we should follow.
I mean, I do think it's been a really positive step forward, and I think I think NHS England should be commended for actually giving us that flexibility, because many approaches have been less flexible over time, and actually to start someone on DARA-VTD knowing that they may or may not be suitable for transplant is good. We know it works quickly, it's good for the renal patients, it's good for the high-risk patients, and then you've just got that option of switching over after 4 cycles or even 6 cycles if you want to. I mean, there's some patients that we've actually even harvested following 4, making a decision not to go ahead, but we may want to keep that option open in the future as well.
Thank you.
Well, the mics are going up. I think one other adjustment we tend to make locally is to withhold the thalidomide in patients who are immobile or at increased risk of VTE, and substitute cyclophosphamide instead for the first cycle or so until they're more mobile. So that's another adjustment we often make.
Question on the floor, yep.
Yasmin.
From both the transplant eligible and non-transplant eligible perspective, can you give us some insights into your real world practice of patient, how you, or what discussions you have with patients on LEN maintenance who are struggling for whatever reasons, toxicities, psychologically, whatever, in terms of when to, when they say to you, when can I stop my LEN? Given that we're not using MRD routinely, what are the practical discussions or factors that you take into account to counsel your patient about stopping LEN?
Am I not allowed to suggest that they have an MRD test? So I guess I'm fortunate to work somewhere where we can send MRD, so that is really helpful for me in that situation. But I think that risk comes, so if we're talking transplant eligible LEN maintenance patients, then the genetic risk of the patient, I think, is important. I think I'd be much less likely to encourage a patient who is high risk to stop, and in fact, using GCSF to support their counts and try and keep their dose up is also something we do, particularly for high risk patients, and maybe for standard risk patients, I'd be more inclined to dose reduce or stop after X number of years. The more time I spend looking at the myeloma 11 data, I become increasingly uninclined to stop maintenance based on that data. So I think, just to be clear, every time we talk about it, I hear lots of different people presenting my slides in different ways, and it's fascinating because I think you can interpret it in a number of different ways. But fundamentally, the key thing it doesn't tell us is what happens if you stop maintenance after a certain duration of time, because in the study, patients were randomized to have no maintenance or to have maintenance to progression. And then we did a series of cut point analyses to try and learn as much as we could. I stand by what we tried to do, but it doesn't, in order to really answer that question, you have to do a randomized stopping study after a period of time on maintenance. So the more we look, the analyses that we have done, it's harder the longer follow-up you have, it is actually hard to define any point at which you could say it's reasonable to stop. So the data we showed is from the first data cut, and we've got a slightly longer follow-up where we can look and see actually even beyond 4 or 5 years, even in those patients who are MRD negative after transplant, the curves still separate. So it's hard to use that and say that stopping is okay. Nevertheless, if a patient's really struggling, we do still stop, because on balance, that's the right thing to do. And I think a lot of us would wish to be able to restart, and perhaps that's the next thing we should try and encourage NHS England to be more flexible on, is that 6 weeks of off therapy and then being able to start at a point at which they've recovered from that toxicity and want to try again at a different dose, for example.
Many a times dose reduction works, so instead of giving 10 milligrams of len, you can give 5 milligrams. Many times you can give it 5 milligrams alternate day. You can give an extra week break. Instead of doing a 4-week cycle, you can do a 5-week cycle, and you can maintain your patient on small dose of lenalidomide.
I think that's right. I think being flexible and giving them treatment breaks and treatment holidays. But there will be a group of patients who really struggle, particularly with the generic brands of lenalidomide. And then I think today, because there are good options at relapses, I don't think there's any point destroying their quality of life with lenalidomide. But it is a balance, and I think I agree with Charlotte. I think if a patient hasn't achieved a CR, I'd be much more inclined to try and persevere with len and just adjusting the dose. Sometimes just giving them a 4-week washout period and then starting again with a low dose or attenuated regimen helps.
There's a question there.
Charlotte, I was interested, on one of your slides, the expected deaths was much higher in the over 80 population. So do you think we're being still too aggressive in that group? And I was sort of interested, you were still going for MRD negativity in the older group.
So no, I would say that we're perhaps not being aggressive enough, I guess. So we're seeing in the context of myeloma 11 treatment, which was, I guess, comparable to Lendex as a backbone treatment, that we're seeing a higher number of excess deaths in the older patients. It's hard to know whether that's because we're under-treating their myeloma or over-treating and leading to toxicity that is a challenge. And I think that's really what fitness was trying to get at, is could we give lower doses, lower toxicity, and enable deeper responses with ongoing therapy, all by dose reducing initial dosing. And that does appear to be what we see in the intermediate group of patients in the results from fitness. It's harder to prove for the frail patients, and perhaps for frail patients we need different approaches. Maybe IRD is not the optimum combination for frail patients. Hopefully DRD is better tolerated, and then we can see in that group what that leads to.
Karthik.
Thank you. We've always complained about NICE not giving us enough therapies to play with, but we now have a lot more. So I have a question for Matthew. There is genuine clinical equipoise now with therapies in relapsed myeloma. What advice would you give clinicians as to how to approach those situations?
I guess I alluded to it in my talk, in as much as I think we've got to establish as much as you can the sort of the context in which you're making the decisions, so the patient factors and the disease factors, and I think patient information and expectation, I think, is probably crucial. And when there is, as you say, clinical equipoise, then actually it comes down to practicalities, and I think we've just got to be open up front around that, and be prepared to not necessarily always offer what the trial data always says is always the best if you're looking at PFS and OS, but to balance that against the individual needs of the patient in front of you.
Can I just ask a quick practical point as well for Amanda's case, where they proceeded down transplant eligible route? We're talking about lower dose melphalan as the first auto. Is that something you would do, or would you not just move to non-transplant eligible if they're not fit enough to get a 200 ml auto in their first auto?
I think, again, we do individualized decisions, but on the whole, I think we do identify certain groups of patients who benefit from melphalan or from an alkylating therapy, alkylator therapy. I think 1114 myeloma is one of those. So we're not so fast if a patient with T1114 type disease doesn't achieve a deep response to induction, we can take them through because we know the chances are they'll deepen their response. So those are the patients we try and get to high-dose melphalan, and if necessary, we do dose reduce. But there might be other patients who haven't made a deep response, and there's equipoise between transplant and not proceeding with the transplant, then I'd be less inclined to push them forward. But remember that if you don't, you have to stop treatment. So that's why the switch to the DRD
Makes a
pathway.
difference.
Yes,
Very good.
absolutely.
So I think that's made a big difference to what we're doing. So we were doing quite a lot of dose-reduced melphalan autographs in patients who'd been started on DVTD to make sure that they could get ongoing therapy. And we're definitely not doing that anymore. If you have a question that they can tolerate it, then switching to Daralen at that point is now possible and likely to be better if you're worried about, the fitness for transplant.
You know, the second case that we had, where I used bortezomib as emergency therapy. So what is, without compromising the subsequent choice of induction pathway? So because we did use DARA-based pathway subsequently. So what is your opinion on it? And does everybody knows that we can use at least one cycle of something like this? So instead of giving just dexamethasone as emergency pathway, you can actually use bortezomib and dexamethasone, and then later on decide what you want to do. At least that way we could rescue our patient. But I don't think that's
actually commissioned, is it?
We have a pharmacist here who helped us out.
I think there's some local interpretation, I suspect. I think it's a very good idea.
Yes.
Very
To
good
be
idea.
clear,
No,
it's
I
an
did want
excellent
to
idea.
actually say that.
Yeah.
Yeah.
So probably to clarify kind of our practice in the East Midlands is that I don't think there's an official NHSC ruling on you can give one cycle, but our experience and practice is that if we discuss it with our regional cancer team, then a single cycle of treatment is not considered to be a line of effective treatment. And so certainly we have flexibility that if you've only had a single cycle, we will then discount that. And I suspect that if you find yourself in that situation, I would have that conversation with you, certainly in England, with your regional cancer pharmacist, because I don't think we're probably the only region that would interpret it that way. But you're right, there's no NHSE kind of commissioned statement that you can do that.
But yeah, but it's a very good idea, and I did want to share that with everybody.
Well, thank you very much to all our panels and speakers. I think we're about out of time or over time. So yeah, thank you very much. Thank you.
So thank you all for attending it, and the online people as well to attending, and Morley family for giving us, and all the sponsors that have generously supported this meeting. And can we remind you of the feedback forms so that we can send you the CPD email to you within a week, and also autumn meeting of the UKMS. And do not forget that all the talks from today are available on the UKMS website as long as you are a member of UKMS, and it is available to download as well. Have a safe trip home and a lovely rest of the day. Thank you.